Now let's talk about mixed platelet and coagulation disorder. So in the mixed platelet and coagulation disorders, we have von Willebrand disease, we have DIC, which is disseminated intravascular coagulation. These are mixed disorders, meaning you have platelet issues as well as you have the coagulation factor issues. So in von Willebrand factor or von Willebrand disease, excuse me, what do we have? Platelet count is normal because they have nothing to do with von Willebrand. Bleeding time is increased because you need von Willebrand so that the platelets can bind to and then aggregate. This is subendothelial collagen to which von Willebrand factor binds. This is fibrinogen here. And PT and PTT. On PT, depending on if it is factor 8, since we know that von Willebrand factor carries factor 8 with itself, so that can increase the PTT. That's why you have increase in PTT. Otherwise, you're normal in PT. What is the notes? Intrinsic pathway coagulation defect, in which you have a decrease in von Willebrand factor that causes increase in PTT, because von Willebrand factor protects factor 8. Second point, defect in platelet plug formation. Decrease in von Willebrand factor leads to defect in platelet 2 von Willebrand factor adhesion. Third thing, most are autosomal dominant. Mild, but most common, look, very important. This is most common inherited bleeding disorder. Commonly presents with menorrhagia or epistaxis. Treatment is desmopressin, which releases von Willebrand factor stored in endothelium. Releases von Willebrand factor stored in endothelium. We talked about it. And that von Willebrand factor will also bind to factor 8 and stabilize it. That's why we were giving desmopressin in hemophilia A8, right? So that's all for the von Willebrand disease. So only two things we have here: increase in PT and platelets can bind. Coming to the DIC now. DIC. Okay, now here I have one more thing to talk about here before we move on to DIC. There's a disease that we talked about, right? That also messes this GP1B. That disease is Bernard-Solier syndrome, right? So how do you differentiate if we have this disease or we have von Willebrand factor disease or von Willebrand disease? So in here you would have, and both of them, when you do the, I don't know why I haven't mentioned that, but when you do the ristocetin test, it's going to become abnormal in both these diseases, in von Willebrand factor and also the Bernard syndrome, Bernard-Solier syndrome. Okay, but how do we differentiate that? In Bernard-Solier syndrome, what we do not have is this increase in PTT. That's the only differentiating features in these two. On top of that, also you have this one that the platelet to von Willebrand factor adhesion is not there. Well, not this one, but the carrier for factor 8. This one. But this is nice to think about these two. But whenever you see, even if you have two options in your question stem. It says Bernard-Solier syndrome or von Willebrand factor disease. I would say always use von Willebrand factor disease because this is most common inherited bleeding disorders. But this is only if you're confused, if you don't get these points, which if you know these points, you're gonna know which one it is. But if you don't, then just choose von Willebrand. And most likely you're gonna get the right answer. Alright, coming to the next thing, what do we have? We have DIC. In DIC, let's read the notes first. We have a widespread clotting factor activation. So the clotting factor, or the factors, clotting factors, they have been activated widespread, which leads to thromboembolic state with excessive clotting factor consumption because you have consumed the factor. So you have consumed the factors, which leads to increase in thrombosis, increase in hemorrhages. Example, blood oozing, very important now. That's the only way we see this thing. Only scenario you see blood oozing from the punctured site or IV sites. DIC. Close your eyes on this side, DIC. But hey, look at the other things. Maybe acute, life-threatening, or chronic. If clotting factors production can compensate for consumption. Again, what do I mean by that? So it could be acute. Acute is life-threatening, that you consumed all the clotting factors. Or chronic. How can it be chronic? If clotting factors production can compensate for consumption. So your body's trying to make more and more factors to compensate for the consumption of them. So that's going to lead to chronic. But what are the causes? So the question is why there's a widespread activation of that those clotting factors. Excuse me. That has to do with some pathology. So DIC has to go with there has to be some underlying pathology that is causing widespread activation of those clotting factors leading to DIC. Some underlying pathology. What is the pathology? Causes are heat stroke, snake bite, sepsis, trauma, obstructive complications, acute pancreatitis, malignancy, nephrotic syndrome, transfusion. The mnemonic is stop making new thrombi. Okay, so just remember all of them. Did these stop making new thrombi? All of them, they are stimulating clotting factors, which leads to low in which leads to consumption of all the clotting factors. This leads to decrease in total amount of clotting factors in the body we have. So these are all the causes, and they're all causing widespread activation of the clotting factors. What are the labs? The lab is schistocytes, increased fibrin degradation, D-dimers, decrease in fibrinogen, decrease in factor 5 and 7. No, 8 actually, my bad. 5, 6, 7, 8. Yeah, factor 8. So you have blood vessel in which you have the clotting factors that have been widespread. There is activation of that. RBCs are coming again, same thing. They're gonna shear through these micro thrombis and lead to formation of schistocytes, which are the Hellman cells. You have the clotting factors. Widespread activation of clotting factors causes what? You're making the secondary hemostasis. Remember, if that was the platelet. Let me erase this and show you. You have the platelet with the GP2B3A with fibrinogen, and you have the other platelet and so forth. That was all the that's the aggregation of platelets, right? But this is weak plug because you have fibrinogen. Fibrinogen gets converted to fibrin, and that forms a great strong plug, and that was done by clotting factors. Clotting factors coming and causing the conversion of fibrinogen to fibrin leads to secondary hemostasis, means very strong plug. But remember, we have the body. The body is like, hey, why are you making so many accumulation of these clotting factors and platelets? So let's kill this. Let's kill this fibrin. So who kills the fibrin? Plasmin, coming from plasminogen. By the activity of TPA, plasmin comes and destroys this. So when you destroy, you're making so many, and you're destroying so many. When you are making so many, you are decreasing your factor, decreasing your platelets, right? But when you're destroying so many, you're increasing your fibrin degradation, which is called the D-dimers. When you degrade this fibrin, this leads to some degradation. It's a byproduct, which is called D-dimer. That will be increased. You are decreasing fibrinogen because you are so much converting this thing into this. So you're decreasing fibrinogen levels. Decreasing factor 5 and factor 8. Because of activation of this common pathway and the intrinsic or extrinsic pathway. So now look at the labs now. And labs will show us all the things I talk about. So you have consumed all the platelets. So you have platelets, low platelets. Bleeding time increased because of low platelets. You have PTs increased because you have consumed factors. You have increased PT because you consumed platelets. Okay. So this is what they were talking about when they said differentiate DIC versus your TTP and HUS. All of them, this guy and this guy, both had microthrombi formation. Both of them, both the disease had microthrombi formation, widespread. But the differentiating feature is in TTP and HUS, it's a different sort of story. But in DIC, you are messing up everything. You're decreasing the platelets, you're increasing the clotting factors, PT and PTT. While in TTP and HUS, you don't have this. All you have is a triad with fever and neurological symptom, or triad with bloody diarrhea. I hope that makes it clear.